Welcome to ICON's Women's Hour Cancer Conversation Talk. I am Dr. Carmen Wong, medical oncologist and medical director of ICON Cancer Center, Singapore. We are delighted to bring you this special event today in recognition of International Women's Day, which is celebrated every year on the 8th of March. This is a very special year for Singapore, with 2021 being declared the year of celebrating women. Our international panel of experts from our network across Australia and Singapore will be speaking with us today about women's cancer and blood disorders and the issues that are faced by women during and after treatment. Today, I'm joined by an international panel of female specialists, Dr. Rebecca Chin, Dr. Lee Guat Eng, Dr. Aniska Małżewski, and Dr. Renee Swires, who each will be presenting a short talk on their particular area of expertise. If you have a question for our doctors, please submit them through the chat function if you have joined us via Webex, or you can enter them in the comment if you have joined us via Facebook. And now I would like to introduce our first speaker, Dr. Rebecca Chin from Australia. Dr. Chin is a radiation oncologist at ICON Cancer Center, Australia, currently practicing at ICON Cancer Center at Ravesby and Wodonga, New South Wales. Dr. Chin treats a broad range of solid tumor malignancy with special interest in breast and gynecological cancer. Today, she will answer your question on radiation therapy, particularly pertaining to gynecological and breast cancer. And I would like to welcome and thank you, Dr. Chin.
Thank you, Dr. Wong. I'd like to thank the organizers for asking me to speak. Today, I'll be speaking on radiation therapy and gynecological cancers. I will like to focus on recent advances. So just briefly, I'd like to just step back in time. So radiation was discovered in the 1890s, and soon after it was recognized that it was potentially could treat cancers quite well. They started using radiation, but with very poor or little understanding of the radiobiology, often they were empiric dosing. Large single doses were delivered. Cancers were really rarely cured, and there was significant normal tissue toxicity, both to patients and, of course, staff were also exposed to radiation. Since then, there's been significant progress. There's better understanding of the biologic effects of radiotherapy. There's more accurate dose calculations. And this talk, I'm going to focus on the imaging and the software and equipment development that have allowed us to more precisely deliver treatments to the tumor while sparing normal tissues. So if you look at the x-rays that were used to treat patients, what we used to do was to take an x-ray of the area that we wanted to treat, and then we would draw out the fields that we wanted to treat. And I'd like you to note, first of all, that the size of the treatment fields, and also that we couldn't visualize the tumor on these x-rays. And on the right here, you see an MRI scan showing a very large cervical tumor. So if you can think that if you can't visualize the tumor, but you want to cover it, what you have to do is give quite large margins to make sure you don't miss the tumor. But also, it also meant that you were treating everything within that area to the same dose as the tumor. So any normal structures in that area also received the treatment. If you make the fields too small, you could potentially miss the tumor and not cure the patient. So the CT scan demonstrates that in this case of the pelvis, we can see this cervical tumor in the bright pink, and in front is the bladder and there's bowel, and right behind is the rectum. So if you're using a large treatment field so that you don't miss the tumor, you could treat all those normal structures as well. This is from a trial that was done. It was called the RTOG 1203, and basically they compared the standard field techniques of using 4 fields to treat the pelvis, and they compared it to a more sophisticated form of treatment. So this is a picture of the fields where the target is the blue and the green, and you can see that the red line covers that very nicely, but that there's a lot of bowel in the way that's also receiving the same dose as the tumor. And they compared it to this technique where they wrap the dose around the target, so the target's well covered, but the bowel is getting much less dose. And basically, so this is just another diagram to show that we can shape the dose nicely and spare bowel. And these trials showed that there was less toxicity in the bowel, shown here. There was also urinary symptoms, which I haven't shown, but basically the more sophisticated technique that wrapped the dose around the target but tried to avoid normal structures showed, as we expect, less toxicity to the patient. Turning now to brachytherapy. So brachytherapy is a form of radiation where we implant radioactive sources, usually just for a short period of time, to treat the tumor. And previously we've used just a standard volume that we would treat, which is the dotted line. And you can see in this diagram that if you have a very large tumor, then you could underdose the periphery of the tumor if you use a standard dosing. And if you imagine that we have a smaller tumor, that we're treating a lot of tissues unnecessarily. So potentially we wouldn't be adding any more to the cure of the patient, but we're just increasing the toxicity. But in those days, they couldn't visualize the tumor. Whereas now we can image the tumor. We can see this is an MRI scan. We can see the cervical tumor very clearly. We can see where the bladder is just in front, and we can see there's bowel and rectum right behind. So we can target this because we can visualize this now. And this is an MRI scan, and this is a side-on view. It's on the side, and it just shows again that the cervix and the uterus, the bladder in the front, and the rectum behind. We use all the imaging techniques at disposable. So this is putting in radioactive implants in, and we're using real-time ultrasound guidance, so we can see precisely where we're putting the applicators into the uterus here, and we make sure we don't perforate the uterus, and it's well placed in the cavity of the uterus to treat a cervical tumor in this case. So this is an MRI scan that shows the applicator in a good position in the uterus. We're treating the cervical tumor, and we can see where the bladder is and the bowel is, so that we can try and minimize the dose to these structures. And this is just a CT scan. It's an implant that I did, and it as for a bulkier tumor, we've put needles in, and this allows us to give a good dose to the tumor and less dose, you can see, to the rectum back here and to the bladder as well, which is well visualized on this scan. So there are publications that show that modern radiotherapy techniques give us better tumor control and with less toxicity. Just take control of this again. As the PET scans have also allowed us to detect spread of the tumor, which may not be obvious on other imaging modalities. In this case, we can see that the cervix cancer has gone to some of the lymph nodes higher up here. And we can then target this with a higher dose of radiation, and you can see that the kidney and the bowel, the kidneys and the bowel have less dose compared to the area that we want to treat. So where are we heading now? Well, we're looking at escalating the dose to larger tumors or higher risk tumors without increasing the toxicity of our treatment. And similarly, for low risk patients, we're looking at reducing the dose to reduce the toxicity of treatment. With increasing sophistication in the technology and software, we are now turning our attention to adaptive treatment, where we adapt the radiation that's delivered depending on the patient's anatomy and the positions of the organs inside the patient at the time the patient is on the treatment bed. So if you have a look at these scans, this is a large cervical tumor, and And this is just to demonstrate that depending on the bladder filling or rectal filling, in this case, bladder filling, the position of the tumor can vary. So this is the patient on the left, the patient's got an empty bladder, and this is the position of the tumor. And on the right, with the full bladder, the tumor has moved back towards the back of the patient a little bit more. So to account for these variations in the position of the target, we usually have to increase the margin that we treat to cover the tumor. We have installed a variant ethos machine to give adaptive treatment. So basically, we put the patient on the treatment bed, we perform a high quality CT scan, and while the patient's on the treatment bed, we can assess the position of the organs and the target, and if necessary, we can adjust the plan and give the patients treatments within a 15 to 20 minute time, so that we are actually targeting the treatment to the patient at the time of treatment. And this allows us to give more accurate targeting of the tumor and minimize the dose to the normal structures. In summary, we are now much more able to accurately assess the tumor extent and the staging of patients. Image-guided radiotherapy and adaptive treatment allows us to give better targeting of treatment to more accurately target the tumor and to use smaller margins. Image-guided brachytherapy allows us to more precisely target the tumor and allows us to give a higher dose to the target while minimizing the dose to the normal structures. So basically, the aim is to try to improve the tumor control and the cure rate and minimize the side effects to patients. Thank you.
Thank you, Dr. Chin, for a very informative lecture. I now welcome Dr. Lee Guat Eng from Icon Cancer Center, Singapore. Dr. Lee is a medical oncologist specializing in the diagnosis and treatment of breast cancer. She was awarded an international fellowship research grant in 2016 and was trained as a fellow in the renowned Dana-Farber Cancer Institute in Boston, USA. She is a program director of ICON's Young Women's Cancer Program, launched earlier in 2020, and will be presenting on these special needs of young breast cancer patients, including pregnancy-associated breast cancer. And let us welcome Dr. Lee.
Thank you, Carmen. So let me just take control of this slide. Okay, good afternoon, everyone, and thank you very much for taking time out to join us for this Women's Hour discussion. Okay, sorry, some lag time there. Okay, so for today, the topic I'm going to focus on will be on young women with breast cancer. You may wonder, why is this topic important? If we look at like modernization and more women postponing childbirth, likewise with increase in Western diet, increase in alcohol intake, we really do see an increase in young women with breast cancer. If we just look at the Singapore numbers, we can see that breast cancer is still the most common cancer amongst female. And if you look at the pink line on the left, you can see that this represents the incidence rate, and it is really rising at quite a fast rate. Hence, it is very important to focus on creating awareness amongst women, not only just young women, but women in general, and also to encourage more women to be aware of their body, to take charge of their health, and to do more self-breast examination. Similarly, we also do encourage women to go for their screening. So for women between 40 to 49 years of age, we recommend mammography screening once a year. For 50 years and above, we do recommend once every 2 years. And why is this topic on young women important? In addition to the few factors that I mentioned earlier, if we contrast this number to the Western population, we see that breast cancer less than 40 years of age accounts for about 4 to 7% in Western population. But in Asian population, this number is higher. In fact, in the local population in Singapore, we see about 1/5 of this breast cancer diagnosed below 44 years of age. And while the treatment principles do not differ from that of the older counterpart, we have to consider numerous psychosocial issues and other issues pertaining to fertility, hereditary breast cancer that the young women may face. So with this, we have set up our ICON Young Women Cancer Program. Why? Because we recognize that they represent a unique subset of patients who really requires a more defined approach. So actually, in this program, we bring them step by step from diagnosis to treatment to fertility preservation options, as well as genetic counseling and also testing options. And we are there with them through every juncture of the cancer journey. So you may ask, what are some of the psychosocial issues that they may face, which are not common in their older counterparts? So first of all, because they are young, they may be at the peak of their career. They have to juggle between work and young families, and sometimes even loans. And they do get a different set of peer pressures because, their peers are seemingly healthy. Hence, they do have pressure when they compare themselves to their peers. And they may also have problems with sexuality, fertility, or even relationship. And it may be a consequence of the hormonal treatment or even a direct consequence of chemotherapy. All this can affect their body image and self-image issues and consequently affect their adherence and compliance to treatment. So the treatment in young women, as I mentioned earlier, it doesn't differ very much in principle from that of the older women. It really still depends on the stage, the biology of the cancer. But because for younger women, they often have a lower index of suspicion, the cancer generally present at a later stage. They can be larger and they can also be more aggressive. Hence, for younger women, we really focus and we prefer a neoadjuvant approach compared to an adjuvant approach in the older women. So in addition to the psychosocial issue, likewise, like I mentioned just now, we also have to consider fertility issue. So I'll just take a few minutes to talk about fertility preservation. Why is it important? I think it's very important to recognize that these women, when they are young, after they complete their treatment, they still have years ahead of them. So it's very important to ensure that they have good quality of life. And from fertility point of view, I think it's important that they are able to pick up their life from before diagnosis. They are able to look towards a fulfilling life of getting married and having kids. Not to say that if you're single and you don't have kids, you don't have a fulfilling life. But I think for most modern women, we will agree that having a choice is what is important. So when we talk about fertility, the likelihood of subfertility really depends on the type of drugs used, the dose given, the current age of diagnosis, and what was the fertility level before the treatment. Some of the fertility preservation methods include embryo cryopreservation, which really is the gold standard, or oocyte cryopreservation. And if time is a constraint, then we look towards ovarian tissue preservation or even ovarian suppression. Last but not least, another important issue is genetic counseling and the possibility of hereditary disease when the disease is diagnosed in a young woman. So in addition to taking care of ourselves, we need to take care of the people around us, and that means our family members. So when a woman is diagnosed at a young age, there is certainly a possibility of it being a hereditary disease. And I'm sure we are all aware of the Angelina effect. So there is a potential, it's very likely that they may be a BRCA1 or 2 mutation carrier. Hence, there is a need for genetic counseling and even screening. And if they are indeed positive, then we need to discuss risk reduction surgery subsequently. So last but not least, just a very short talk. We may discuss more in the Q&A later, but I urge all the women to stay positive because in recent few years, there's been a lot of research and a lot of progress specifically in this breast cancer area, and there's a lot of new drugs available. So with that, I will just end my talk here. Thank you.
Thank you, Dr. Lee, for a very interesting and insightful lecture. Now I would like to welcome our next speaker, Dr. Aniska Małzeski from Icon Cancer Center in Australia. Dr. Małzeski is an experienced medical oncologist based in Icon Cancer Center, Wesley, Chermside, and Northlake in Queensland. She treats a broad range of solid tumor, including melanoma, gastrointestinal tumor, pancreas, and lung cancer. She has an ongoing passion for medical research and continues to be actively involved in clinical trials. And she is also committed to teaching and is currently holding a senior lecturer position at the University of Queensland. Let us welcome Dr. Małzeski. Thank you.
Thank you very much, Dr. Wong. All right, so today I will be speaking about some of my interests, including oncoimmunology, and I'll be briefly discussing some of the research that I have been involved in. I'm currently a PhD candidate in association with the University of New England and the Queensland Institute of Medical Research. And our topic with PhD is the role of metabolomics, or metabolites produced by the gut bacteria, and how they might enhance responses to immunotherapy. We'll be looking at melanoma, but responses to immunotherapy in general is what we're looking at. So here we have a puzzle, and you can see some of the pieces are missing and some of the pieces are coming together. And this perhaps reflects the landscape of oncoimmunology. You can see in the upper left-hand corner, we have Drs. Jim Allison and Tatsuko Honjo, who won the 2018 Nobel Prize for Medicine and Physiology for their astounding work in immunotherapy. And in the bottom right-hand corner, you can see a patient that was treated by Dr. William Coley, a surgeon, in 1908. William Coley is perhaps one of the forefathers of immunotherapy. He was able to show that patients with cancer who had post-operative infections went on to have better outcomes and longer remission periods following the infection compared to those who didn't have these infections. And the reason for that is that the infection may have stimulated the patient's own immune system and immune response to try to fight off their cancer. And in the middle slide there, you can see the gut and a representation of the gut microbiota. So we all have a gut microbiota, and there is now research to show that it may in fact be influencing our immune response. So one of the areas that I focus on is melanoma. Melanoma is really almost a poster child for very immunosensitive cancer. Queensland, of course, is the capital of melanoma worldwide, and immunotherapy is one of the main treatments for melanoma. So now we have access to some wonderful drugs. However, we still know that only 30% of patients may have a long-term response to treatment with single agent therapy. A small proportion of patients, however, can go on to have a substantial remission, and some are even cured. The 5-year survival for advanced or metastatic melanoma in general remains around 50 to 60%. So the question is, why do responders respond? So what is immunotherapy and how does it work? Immunotherapy has had a lot of press attention recently and is one of the most recent advancements in cancer therapy. Immunotherapy generally is a group of drug treatments given to help the patient's immunity to fight the cancer. In the left-hand panel, you can see a killer T cell trying to engage with a tumor cell. And what that cell should normally do is kill the tumor cell. But our immune system has these things called checkpoints in place. And so when the checkpoints are engaged, the T cell cannot kill the tumor. So in the blue marker, PD-1 binds to the PD-L1 ligand. That's a block and it cannot proceed. In the next panel, you can see the patient has in fact been given a monoclonal antibody such as Keytruda or Opdivo, and they're represented by the red triangle or the yellow sort of circle, and they're binding onto those checkpoints and blocking them. Now these checkpoints are blocked, and the T cell can proceed to kill the tumor. And in the far right-hand panel, what you're seeing there is a patient's tumor being sliced up as it is in the pathology lab. And in the bottom, you can see some green immunofluorescence with CD8. So that patient's tumor has got a lot of CD8 or killer T cells in there. And in the red immunofluorescence, you can see the tumor is expressing a lot of that PD-L1 ligand that we've just been discussing. So what that means for this patient, high PD-L1 expression, a lot of white cells in that patient's tumor is going to have a very good response to immunotherapy. And this slide shows some of the mouse work which has recently been published. And it really highlights the role of the microbiota that I've been discussing, or those gut microorganisms in a mouse model nonetheless, but giving us pretty compelling evidence that the microbiota is influencing immune responses. So here we've got two different types of mice. They're genetically similar, but what's different is these mice have a different microbiota. On the left, you have a Jax mouse, and on the right, you've got a TAC mouse. The TAC mouse, the melanoma grows quicker. When the mice live in separate houses, the TAC mouse, their melanoma grows quite quickly. The Jax mouse the melanoma grows more slowly. When you house the mice together, their microbiota is thought to get a bit stirred up, and you can see the TAC mouse now has slower melanoma growth. Now, in the next part of the panel, the mice are given the TAC mouse is given different treatments. Firstly, it's given no treatment just to show how quickly its melanoma normally grows. In the next little arrow down, it's given PD-L1 monoclonal antibody, so something like Keytruda, and you can see the tumor slows down. In the third arrow down, it's given a fecal transplant. So we're giving poo from the Jack mouse into the TAC mouse and changing its microbiota. And you can see the tumor is slowing down due to the microbiota change. And in the last arrow down, the mouse is given a combination of both the monoclonal antibody, so Keytruda, plus a fecal transplant. And the melanoma growth is slowed down even more substantially. So this is a model, but nonetheless, it provides us with evidence that the microbiota for these animals is driving some of their immune responses. So this is the work which is interesting to me at the moment, and it may have application for different cancer types. This diagram is from one of my recent publications from the Journal of Immunotherapy for Cancer, and it shows some of the work we'll be doing at QIMR. We know that when we eat, food is broken down by the microbiota and turned into different metabolites. Some of these metabolites are things like short-chain fatty acids. And we think that the short-chain fatty acids are influencing T cells, so white cell development. And those white cells are, in fact, what can cause the tumor to break down or to be killed. So with the right combination of metabolites, perhaps immunotherapy responses could be made stronger. So in my PhD and with the research with ICON and QIMR, we're proposing to undertake an observational study of patients with advanced melanoma who are having monoclonal antibody checkpoint inhibitor therapy. And we would like to compare the bacterial metabolite composition between immunotherapy responders compared to non-responders. We'd like to work out what the differences are. And the long-term aims are perhaps to find a biomarker to pick out the people who are going to respond better, and perhaps to come up with some sort of metabolite or molecule that could be supplemented to those who are less likely to respond in order to enhance their immunotherapy responses. Thank you.
Thank you for a very interesting lecture. So next time we not only exchange food, we need to exchange poo to make our immunity better. That's so exciting. Thank you. Our last speaker, it is Dr. Renee Squires. We are changing notes. Dr. Squires is a clinical hematologist. She has extensive experience in caring for a wide range of hematological conditions, both malignant and non-malignant. And that includes leukemia, lymphoma, melanoma, and management of thrombosis. She has special interest in the treatment and management of women's health and obstetric hematological, and passionate about advocating the highest possible care and outcome for patients. And she is currently consulting at Icon Cancer Center at Southport and South Brisbane. Let us welcome Dr. Swires. Thank you.
Thank you, Dr. Wong, for that very kind introduction. I'll just take control of this. All right. So I am changing gear somewhat, and I'm going to talk about what are the normal changes during a woman's journey through her pregnancy, and in particular focusing on the hematological system. So there are multiple changes that happen to your blood during pregnancy, one of which is anemia, or an overall decrease in the amount of red blood cells in your system. You also get an increase in your circulating white cells. You get an overall decrease in the platelets, or the cells that help to form a blood clot. And paradoxically, you get an increase in the proteins that are involved in making a blood clot. Your body also has a diminished ability for your body to break down clots. I'll go through each of these individually. So first thing is anemia. It's very common for a pregnant woman to become anemic. And why is that? It's not because your body doesn't produce the red blood cells, it's because it's a dilutional effect. So you increase your total blood volume, and blood is comprised of multiple things, including red cells, white cells, platelets, but also your serum, plasma, and proteins. So overall, the total blood volume actually can increase from 1 litre to 1.5 litres over the course of the 40 weeks. Your red cells do increase, but they just don't increase at the same rate. And I've got a slide that comes up that shows what the difference is. However, it's really important for us to be able to identify when the anemia is an expected gestational anemia, or is it secondary to something else. And the most common things would be a nutritional deficiency, in particular iron deficiency. Some women may need an iron transfusion during their pregnancy. The next thing is there a source of blood loss? And sometimes these things can occur from either hemorrhoids or a gastric bleeding ulcer, or even something more sinister. One thing that can happen is you can have a destruction of red cells or hemolysis. This can be from a multitude of problems. And the one example I've given there is things like thalassemias, or even sickle cell anemia, and happen when somebody is pregnant. You can have a sickle cell crisis. And then finally, and this is rare, to have a decreased ability of your bone marrow to produce red cells. And this can range from multiple things like congenital causes, all the way through to acquired conditions such as bone marrow infiltration with malignancy, or indeed leukemia. So this slide just represents the difference in the total blood volume. So you can see a majority of the blood volume as it increases over 40 weeks is really secondary to that plasma expansion. The red cells just don't increase as much, and that's where the dilutional effect occurs. So most of the, you get increase in the liquid component as well as the plasma and proteins. So, I mean, why does the body do this? And it's because it needs to increase your blood supply, because the uterus is enlarging, and it's you've got a growing fetus in there, and you need to be able to supply appropriate amount of hemoglobin, oxygen, proteins, and nutrients to the uterus and the fetus. It also is a protective mechanism. So some mothers unfortunately do bleed quite a bit during labour and can lose litres of blood. And this is really a protective mechanism in the event that this may happen. So the plasma volume postpartum, post-labour, what happens? It does decrease immediately after delivery, and then it slowly increases again. But by 6 weeks postpartum or post-delivery, your plasma volume should be back at baseline. So I'm going on to platelet count now, and I'm going to just start with pictogram here to show that the difference between what the platelet count of a pregnant woman is versus a non-pregnant woman. And you can see that generally the shift is down in all pregnant women, and I'll go through why that might be. So the technical term is thrombocytopenia for this, and it just means low platelets, and it's displayed as the purple cells in the slide there. Platelets have a really important role in the body, and they're there to help form a clot. Gestational thrombocytopenia is something that is normal for some women, and platelets can be as low as 70, and the normal count is considered to be between 150 to 400. Now, the important thing to be able to do is separate gestational thrombocytopenia, which can be something that is normal during a pregnancy, from something that could be potentially serious, is that the patient must be asymptomatic. No bruising or bleeding should be occurring with these platelets being slightly low. It normally always occurs in the third trimester. If it happens in the first or the second trimester, we must be thinking about other alternative diagnoses. It always resolves postpartum, and generally at 6 weeks, again, it should have resolved. And there should be no issues with the mother, indeed the growing fetus. So when are they a problem? When should we be concerned about low platelets? And one thing is immune thrombocytopenia, and that's when your own body starts to attack your platelets. The second thing is HELP syndrome, which is known as hemolytic anemia, elevated liver enzyme, low platelets, and preeclampsia or eclampsia, and these are very connected. These will show issues with both the mother and the fetus, and neonatal issues can occur post-delivery, so very important to be able to recognise these. And there can be a real issue with spinal anaesthesia or epidural pain relief if the platelets drop below 50, and we need to be able to identify that. It can also be, very sadly, potentially fatal if not dealt with swiftly. I'll go on to white blood cells now, and these are your foot soldiers. They fight infections, and while you're pregnant, you do have an increase in your estrogen and your cortisol levels, and this can have an impact on your white blood cells. Normal levels are considered to be 3.5 to 12, and while a woman is in labour, her neutrophils can be as high as 30. Again, this is a protective mechanism. It's designed to allow the female to be able to have ability to fight infection. Labour can be potentially an area where we can have infections with tears and bleeding. Again, all white blood cell levels should return to normal within 1 to 2 weeks. And finally, I'm going to talk about clotting factors. So conversely to our platelets dropping, our clotting factors increase. These are just proteins that allow the body to form an effective clot or a platelet plug. They're at their highest in the third trimester. And there is a 5 to 6 fold increase of a woman developing a clot while she is pregnant. This is secondary to the increase in the clotting factors, but it's also secondary to a gravid uterus, which is pushing on major veins within the body. Again, it's a protective thing, protecting the woman from potential blood loss during delivery, and these things should return back to normal within 6 to 8 weeks. We need to identify patients who have already a thromboembolic disorder or a clotting disorder, and we need to be able to manage these patients because their risk of clot increases quite significantly. And we do this in conjunction with obstetricians, anaesthetists, and high-risk pregnancy clinicians. And that's my talk, and I'm happy to answer any questions. You can send them there after the talk if you need to.
Thank you to all our doctors for some very interesting presentations. We will now begin a live question and answer session when we hope to answer most of your questions. If you're attending through the WebEx session, please submit your question to all the panelists via the Q&A section found on the right-hand side of your screen. If you're joining us on Facebook, please send us your question in the comments. Please feel free to cite the city and the country you're from when submitting your question. We also have some pre-submitted questions to thank you to everyone who have sent us the question ahead of time. And while waiting for this to be, can we invite all the panelists to go on to the screen? Now, the first question that has been pre-submitted is from Singapore. There is a question from one of the lady asking post-lumpectomy and radiation. Is there still any cancer cell remain in the breast? And this particular lady has stage 1 disease and she received tamoxifen. She would like to know what are the other things that she can do to prevent the cancer coming out. And maybe we would like to address this to Dr. Chin, who is a radiation oncologist.
Thank you, Dr. Wong, and thank you for the question. It's a very good question. So the risk of recurrence in the breast after a stage 1 breast cancer treated with wide local excision, lumpectomy, radiation, and endocrine treatment is actually very low. I think it's less than 1% per year. But it's clearly very important to continue taking the hormonal treatment, the endocrine treatment that's been prescribed, if that's been prescribed, and to have regular checkups. So your doctor will have a follow-up regime. Usually it's clinical examinations every few months for the first few years, and then that gradually reduces in the number of times that you go back to the specialist. And once a year, there's usually imaging of the breast, usually with mammograms and ultrasound. But the risk of recurrence should be quite low.
And what should she do? She has done her radiation, she has done her tamoxifen for 5 years. And is there anything that she should be cautious about her lifestyle?
So we know that having a healthy diet, exercise are very important, and the follow-up. I don't know, Dr. Lee, whether you have anything else to add to that.
Sure. So usually for breast cancer risk factors, we divide it into modifiable and non-modifiable risk factors. So really I think for what we can do, it will all boils down to the modifiable risk factors. And as Dr. Chin correctly mentioned, we often encourage our patients to exercise regularly. So WHO has a recommended guideline for cancer survival, at least 150 minutes a week. So if you divide it by 5, then we recommend like 30 minutes 5 times a week, twice of weight training. Very difficult. I have problem keeping up with that, but often we try to encourage our patients to do that. Healthy diet, according to WHO again, so cut down on your red meat, increase your grains, vegetable intake, and also decrease alcohol intake. Try to keep to a good BMI, because we know that for women, our fat cells do produce some hormones. Yeah, so basically a healthy diet and lifestyle.
Thank you. This is a woman's talk, so there's a lot of women's questions, sorry. So this next question, maybe I'll address to Dr. Lee. If a lady has breast cancer in one breast, what is the probability that the other breast will be affected in time to come?
Okay, so I think the question is really asking about recurrence risk. So we have actually already answered some of the component of reducing recurrence, and that's with the modifiable risk factor. But for breast cancer patients, I think it's also important to look at a few other factors. So I think for breast cancer recurrence, it boils down to the stage of the disease. So
Dr. Lee, we're talking about the other breast. Dr. Lee, talking about the other side, not the same side, sorry. So just demonstrate side.
Okay, sure. So for the contralateral, the other side of the breast, then there are some factors which really boils down on whether it may potentially be a hereditary disease. So for younger women, if they are less than 40 years of age, we recommend for them to go for genetic counseling and screening, because if they are BRCA1 or 2 carrier, then their lifetime risk of having breast cancer in the same side or opposite side will be increased to as much as 70 or 80%.
Okay, thank you. The next question is a question, I think different doctor may have different answer. And I would like Dr. Malczewski to answer. This lady asked a question, what does remission mean? Does it mean that all the cancer are gone? Or when the cancer treatment remain the same and there's no change in size? Because we keep saying that you're in remission. So she's asking a very basic but important question. What does remission mean? So maybe I get Dr. Malczewski to answer, while probably teaching medical student on this too.
Yeah, so I guess to me, the word remission would mean there's no evidence of the cancer. That's in terms of either on the blood tests clinically, so on physical examination, or on the imaging, so for example on the CT or PET scans, and that the doctor is reasonably confident that the patient will remain that way for the foreseeable future. So that's the context in which I would use the word remission. Whereas if there is still evidence of the cancer on the scan, but it is stable, then I would probably not use the word remission. I would say that the cancer is stable and hasn't had any growth, and that may be, you know, a good thing depending on the exact context.
Thank you. Let's take a question that is more academic. There's a patient from Singapore. She would like to know what is the newest in cancer treatment, both clinically practiced and in research. And we have two speakers here who spoke very extensively on immunotherapy. Maybe we'll get Dr. Melczewski talking about immunotherapy. Maybe Dr. Renee will be talking about CAR-T treatment as a very brief discussion on this question.
So in terms of what is the newest research, so as Dr. Huang has said, my interest is immunotherapy, and there's been a lot of research interest in immunotherapy for solid tissue cancer over the past number of years, and certainly a number of drugs have already entered the pharmaceutical benefits scheme in Australia for a variety of indications such as lung cancer, melanoma, certain lymphomas, kidney cancers. These are now in use. There's a lot of research which is ongoing in terms of immunotherapy, so either immunotherapy combinations, so sometimes we might be looking at two immunotherapy drugs such as, for example, Yervoy and Opdivo in melanoma. It's combination immunotherapy. Trials might be looking at chemotherapy plus immunotherapy combinations, so there's good evidence to give both for certain solid tissue types. Some trials are looking at vaccine therapy plus immunotherapy. Those are some of the latest things. So these are all drugs designed to try to remove those immunological checkpoints and try to activate those foot soldier cells, those cytotoxic T cells, to enter the cancer site and start killing off the cancer. And there's a lot of interest in, as I've said, why some patients respond really well, and certainly why some tumor types respond very well and why others don't. So we refer to those as immunologically hot or cold tumors, hot ones being where the white cells can go in and kill the tumor. And then there's a lot of interest at the moment in the cold tumors and why some patients, some tumor types can't seem to mount a really good immune response. So I think that's the way that research will be going. It'll be heading into biomarker development, selection of appropriate patients for immunotherapy, perhaps bolstering immune responses and trying to turn non-responders into responders, and immunochemotherapy combinations.
How about Dr. Swires? Any thought, just a brief talk on CAR-T, which is a very hot topic at the moment in Singapore?
Yeah, sure. CAR-Ts are really exciting, and T cells are just part of your normal immune system, and they can sometimes detect some cancers, but occasionally cancers can escape this immune control. So we are trying to engineer your own T cells, which are collected from the patient. They are taken to a lab where they are engineered to attack a specific type of cancer. And this is done by attaching to the T cells something called a chimeric antigen receptor, and that's where the word CAR comes from. They are then basically infused back into the patient where they can multiply by themselves and go and treat the cancer. And it's quite exciting that we can do this instead of maybe not relying so much on stem cell transplants. And we're in the hematology field, we're currently been using it and quite successfully in things like acute lymphocytic leukemia in children in particular, the large cell lymphomas, as well as multiple myeloma.
Thank you. The next few questions are addressing to Dr. Lee. And there's a question from Ms. Tay talking about your view on immunotherapy for triple-negative breast cancer. She wants to know, is it really a guarantee for better result? And in the same token, by another patient, she wants to know what are the side effects of immunotherapy in breast cancer. So I will invite Dr. Lee to answer those two. Thank you.
Okay, so I think we can categorize it into early stage triple negative breast cancer versus late stage. For metastatic advanced triple negative breast cancer, it's already been FDA approved, and locally we are also using immunotherapy in the treatment, and it has been shown to improve outcome. I think it is a little bit more gray in the early stage cancer for triple negative breast cancer, because the first readout, the initial readout from the clinical trial, which is Keynote 522, showed that there is a 14% improvement in what we call the pathological complete response, meaning when the patient have the chemotherapy with the immunotherapy, and we compared this group of patients to just chemotherapy alone, after completing the treatment and at surgery, 14% increase in total response, meaning all the cancer has melted away. So this is the readout from this trial. However, the regulatory approval is still pending because the long-term outcome is still not out yet. So I would say, will I use it for my patient? I think, if we have patients now, like sitting in my clinic, I can't possibly wait for the long-term outcome. But I think patient selection is very important. In young women with very aggressive disease, high-risk disease, will I opt for this treatment? I will probably discuss it with the patient. And if they are agreeable to undertake the treatment, including being able to accept the side effects, then I'll most likely recommend this treatment. So coming to the side effects, I think our panel doctor also worked with the immunotherapy and will probably know that the immunotherapy side effect is not really a walk in the park. So some patients may not get a lot of side effects, but we can have a lot of possible side effects with immunotherapy, and it can be multi-system because it can activate our immune system, and it can lead to potentially a whole host of autoimmune side effects.
Thank you. Let's address the next topic, which is a very hot topic. It's talking about COVID vaccine in patients who have had cancer. One, during treatment with chemotherapy. Two, during treatment, post-treatment on surveillance. Three, patient receiving immunotherapy maintenance. It has been because COVID vaccine is made available in our country, in Singapore. So I believe that has been asked in many incidences. So I would like to get Dr. Lee to answer the question on COVID vaccine during chemotherapy and post-treatment on surveillance. And we will get Dr. Masesky talking about immunotherapy and COVID vaccine.
Okay, so locally, and also we do follow the National Comprehensive Cancer Network guidelines for survivors, especially for patients who are not on active chemotherapy, meaning for example, for breast cancer patients on hormonal treatment, we will certainly recommend for them to go for COVID vaccine, provided they do not have active contraindications. But for patients who are actively undergoing chemotherapy, especially if they are immunocompromised, I think this is a bit more gray because there's no real data in the vaccine trial for this subgroup of patients. So we will still recommend for them to consider the vaccine, but of course, there's a lot of unknown with regards to efficacy.
Thank you, Dr. Masesky, about patient on immunotherapy maintenance and COVID vaccine.
Yes, thank you. So the current guidelines, which we have from Memorial Sloan Kettering, which I have read, recommend that patients who are on immunotherapy should receive the COVID vaccination, that immunotherapy should not be paused, and that you might just want to plan the timing because there might be a few highest risk of side effects from the vaccine within a couple of days of receiving it. So you might want to do that, plan the timing with respect to the immunotherapy day, but certainly we recommend that patients on immunotherapy proceed and have the vaccination.
Right. So let's come to a lighter question. We have been having very serious questions, though this question is very common. This is patient post-cancer treatment for breast cancer. And is it safe for them to use vaginal estrogen cream? And let's make it a bit more complicated. Patients who are triple negative, patients who are hormone positive. And what is your opinion on Mona Lisa touch therapy for vaginal atrophy, which is a light therapy to do vaginal rejuvenation? I don't know who wants to take this question. Maybe I will get guanings because you do, young woman. Dr. Lee, please.
Okay, so I think there has been some literature write-up with regards to vaginal estrogen. So no real contraindication for vaginal estrogen. And after all, I think quality of life of our patients is very important. Yeah, so that's my view on estrogen therapy, topical estrogen therapy, not systemic.
How about Mona Lisa?
I have no experience with that.
Anyone who have some idea about Mona Lisa therapy? No, okay, I will answer this because I've been asked this question before. So this is actually a form of light therapy, like people doing IPL for the face. So it is a form of rejuvenation. And a number of gynecologists and also non-gynecologists has been doing that. And because it's a non-hormone measure, it is a very personal thing. Some of my patients feel very strong about it and favor it, and others say the result are the same. So I believe that safety-wise, yes. Efficacy-wise, I think it's very individual. So you might need to speak to your local doctor. But in this part of the world, I don't think it is. I think it's relatively costly. So it is something one might want to look at. All right, and we have probably time for another two more questions. Okay. How does going through treatment of radiation and chemotherapy affect female hormones? So I let Dr. Chin answer the radiation part and Dr. Lee answer the chemotherapy part. How does this treatment affect female hormones?
So it depends on the area that we treat. So if we are treating the pelvis in a premenopausal woman, then we know that ovaries are very sensitive to radiation and that we will likely cause a menopause. So we would normally talk to our patients about that happening if we had to treat the pelvis in a premenopausal woman. There is documented, there are endocrine effects if you treat the brain, especially in young people, and that can have endocrine effects as well. And usually children who have a cranial radiation are followed up by the endocrinology clinic as well. But if we're treating other parts of the body that is not affecting the ovaries or the part of the brain, then we don't think there will be any significant effects.
Okay, Dr. Lee?
So the treatment really depends, the treatment on fertility and hormonal issue really depends on what type of chemotherapy treatment for what type of cancer. So if we just talk about breast cancer per se, the chemotherapy treatment for early breast cancer is actually gonadotrophic, so it affects the fertility, and it then depends on the age of the patient at diagnosis. So for very young women, if they are like 30 plus years old or 40, early 40s, there is a chance that they can stop having their menses for maybe 1 to 2 years, and they may then resume their menses subsequently. But for women who are closer to menopause age, so let's say like late 40s or 50, the chemotherapy may just render them menopausal.
Okay, thank you. One last question. So this is an International Women's Day. I have a question talking about what is the cancer prevalence among transgender? This is an important question, and maybe the panelists would like to answer this otherwise important question. What is the cancer prevalence among transgender? So I believe we are talking about, in this case, must be from a male to a female, rather than the other way, because we're talking about International Women's Day. So we're talking about a male gender transforming into a female. Anyone want to comment about the cancer prevalence rates?
So I think for many years there has been a lack of studies, scientific studies on this topic. Well, I mean, in Singapore it's not very common and we are not very open with this topic yet. But over the last few years, I think there are more and more literature surrounding this topic. So we also begin to understand a little bit more, and we see that for transgender male, because they need to go through a lot of hormonal injection for them to convert their sexuality. So they do indeed have an increased risk with regards to breast cancer per se. And hence, I think we are starting to be more aware, and going forward, we may even have in line, you know, some guidelines with regards to screening for these patients.
Yeah, thank you. Excellent answer. And I believe that we are coming to the end of our talk, and I would like to take this opportunity to thank you, all our international speaker for this afternoon, for a very important and very informative afternoon. And thank you for all the audience sending in question earlier and participating in the question and answer session. We apologize that not all the questions are being answered. Some of them we would like to answer you in person by email, or if that is needed. And we would like to take this opportunity to thank all the panelists and everyone attending a very good afternoon and the weekend ahead. Thank you very much.
Thank you.
Thank you, Dr. Wong.
Thank you.